Want to learn more about substance use? Maybe it's something you're silently experiencing, or you have a loved one who needs help. Check out Psych Hub's Mental Health Ally certification. We have a 1-hour course dedicated to substance use awareness that covers overdose warning signs and withdrawal, and resources to get help. It's only $15. Or you can complete the entire Mental Health Ally certification for just $99. Visit psychhub.com/learning to get started. Hi, I'm Marjorie Morrison.
And this is Patrick Kennedy.
And you are listening to the Psych Hub podcast, The Future of Mental Health. I just love Linda Rosenberg. For those of you that don't know her, prepare to be inspired. She's the Director of External Relations at Columbia Psychiatry, and I'm grateful to call her a mentor and a friend. This woman is the trailblazer in mental health, a healthcare architect and true reformer. She led the National Council for Behavioral Health for 15 years and helped secure important policies we have in place today, like the Mental Health Parity and Addiction Equity Act and the Excellence in Mental Health Act. What I love about her is that she's not afraid to challenge the status quo or to do things just because that's the way they've always been done. She's tired of mental health constantly having to justify itself or spend too much time promising to save money in different areas. I mean, after all, you never see other specialty or diagnoses talk like that. You treat it because it's the right thing to do. I hope your headphones are charged because you are in for an amazing and thorough discussion of how much painstaking effort has gone into getting mental health care to where it is today. We still have a long way to go, but we're definitely on the path.
Linda, thank you for joining us in not just this podcast, but in the mission at Psych Hub for disseminating greater literacy around the evidence-based treatment models that are out there, but which we both know often don't get out to the providers who need them the most because they really care, have a vocation to serve. But of course, the system isn't there for them in so many ways, which when you were head of National Council, you worked so well and effectively to help break down so many of those barriers. And of course, we worked together on one of the biggest barriers of all, and that was the payment barrier through the insurance discrimination that existed. And I want to thank you for helping us mobilize great coalition of support for the parity law, which of course we are still mobilizing to enforce it all these years later. But which we're seeing some promise that we're finally getting there with some recent decisions that we've seen come down from the courts. But welcome, and thank you for joining us for the podcast.
And thanks to you for your leadership. You know how I feel about you and your family and all that you've given to people who are struggling with mental illnesses and addictions. So it's always special to be with you. And it's special also to be with Psych Hub and Marjorie and her team. You know, the timing of the growth of Psych Hub and my coming to Columbia really came together for me very well, because one of my missions is just as you expressed it. It's to make sure that the amazing expertise that is housed within the Columbia Department of Psychiatry, you know, our chair, Jeff Lieberman, and his faculty of 1,000 actually have expertise in every area. And yet this is my first experience in an academic medical center. And it's further underscored the gap between what research, training, and, you know, effective clinical work can produce versus what many people and their families get. And how do we close that gap? And so this is kind of a new perspective for me in trying to address that.
Well, I'll tell you, academia needs someone who knows how to make things happen on the street. And your gift has been your political acumen to get the powers that be to move in the right direction in Washington, D.C. You've really quadrupled the size and influence of National Council. Maybe give our listeners a little bit of a perspective of the growing power of the mental health advocacy movement as it relates from your own perspective, trying to bring in all of the disparate kind of groups of providers and other interested parties who all have a like interest, but had never been kind of coalesced until National Council kind of brought them in under the umbrella that you helped provide.
We were just really contributing to what, the drum you'd been beating for years about people coming together and the power we have. The National Council is in a unique position. And, it was a solid organization when I got there, although much smaller. And the one thing, if I have to say I'm good at anything, it's really knowing talent and being able to put together an effective team. And that's what I spent a lot of time doing. And then, working alongside them. But I think what was interesting about the National Council, it came out of your uncle's, community mental health movement. That's how it got established. Those original community mental health centers that came into being in the 60s formed an association. And it had a different name then, but it was an education and advocacy group. And so we were able to take that because we had members around the country and really open what we called a big tent, which was if you were involved in serving people with a mental illness or an addiction, you as an organization could be our member, and we would be able to be a voice for you in DC, coordinating very much what you were also trying to do at the state level. And so we created a home, I think. And I think, very often, organizations take on a lot of the attributes of the leader. I always say what the leader wants done is what gets done. And because I grew up in clinical work and then in operations, I'm always very interested. Actually, this is, I think, a bit of a funny story. Before I went to Washington, I went to Albany as the senior deputy commissioner of mental health after, running a state hospital, running clinics, running housing programs, directly working with families and adults with serious mental illness. And when I got up to Albany, and got together and created a team, I said, this is fun, making up policy, because it's someone else's headache in how you implement it. And I think that's been the experience, Patrick, that you've even seen with parity, right? You created fabulous law, and it was years of work to pass that. And now there are years at work at implementing it and making sure it's implemented the right way. So I think the National Council has that perspective. It's not only about making policy, it's understanding how change will happen or won't happen at really the place where patients and families are served.
Well, Frederick Douglass said it best when he said, power concedes nothing without demand.
Right.
And you have been demanding. It's important for people to hear this conversation because we all want a much more effective, available, affordable mental health and addiction treatment system that we can access for ourselves and our loved ones in the same way we expect other services, and even in more rapid fashion. The only way that's going to happen is not some one-off solution. It's going to take a coalition. It's going to take a movement. It's going to take a real getting in the trenches, as you've just described, at various levels. It's going to take a federal level and a state level and the local level. And you've really helped understand that it is the mechanism by which we collaborate that's going to be the decider of how a person gets better. In other words, if we include, just as you described, that personal clinical piece with the family, the individual, the family piece, the housing piece, and someone would scratch their head and say, well, what does housing got to do with mental health? And then you would answer, everything.
Right.
And then, of course, all of the medical services and other support services all have to be integrated. Huge complexity because these illnesses have enormous complexity themselves. And talk to us about this new model. I just have to say to you, when I see the private sector out there citing your model as their model, They say there's no better, way of complimenting someone than, repeating what they've said to do.
I love that. I mean,
And they're doing that here in New Jersey. That CCBHC model, the Certified Community Behavioral Health Centers, they are so proud of it. And I keep saying CCBHCs, and of course it's not a CCBHC, but they're talking about it because it is. It's really a page out of your book. So let's talk about that, because prospective payment, I think, is a concept that people listening may not appreciate. Why can that be such a game changer as opposed to the current, retroactive model of payment?
This is complex, and we're really getting in the weeds. Something I love, but I know made me not a very good advocate on the Hill, because you have to have a clear and simple message, right?
Right.
And you've got to drive it home. And I tend to think the details are important, and they are, but not necessarily at some levels, right? But if you want to get in the weeds, it's interesting. One of the things at the National Council that I had to remind staff about is when people imitate what we do. So, we spent also a lot of time about our brand, because I think this is a marketing world. And if you're not branded and people don't know what you're doing, it's like it never happened. So when people began, imitating our conference, we had staff who'd get upset. And I would say, that's the best thing. The only thing we have to do is innovate all the time. Always be getting better. It was the same thing with mental health first aid. 15 years ago, when I first heard about it, we brought it to the US. It was new. Now Psych Hub has an equivalent. There are other courses, and all that is exactly as it should be. There is room for lots of things. So one of the things we were struggling with, and as you well know, Patrick, is public behavioral health clinics and organizations are usually independent not-for-profits with their own boards, right? They receive primarily state and federal money, but they are very different from community health centers, which are federally connected and federally funded. And that was a model I became very interested in when I was back in New York, and became, looking at how they had improved care. Because at one time, those health centers, those community health centers, sometimes called federally qualified health centers, had really not been known for excellent care. And they made an effort and said, we're really going to close the gap between what we've been doing and what research said we should do in areas of diabetes and heart disease and oncology and the whole spectrum of health. And so we looked at these behavioral health organizations that get paid fee for service, aren't allowed to make a profit, by the way. And so when we talk about risk and there being in risk-based contracts, we have to remember that are there to serve their community, as your uncle John F. Kennedy envisioned back in the 60s, were really struggling. They didn't have the resources to hire expert staff. And one of the things I've learned, because I'm also, we do some work in the private world, private companies, is when a company wants to adopt a new service, a new way of doing business based upon new information, they raise millions of dollars in capital. They hire experts in that area. Well, in the public mental health arena and addiction arena, they don't have any resources to do that. They can't even, for a while, they weren't even supposed to have supervisors. It was all about flattening the organization. And so we saw that care was really not as effective as it could be. They had well-meaning staff, they had well-meaning boards, but there was this tremendous gap. And so we said we have to go back to the future and create these organizations which Congress named Certified Community Behavioral Health Centers, CCBHCs, and that they would have standards that are the same across the country. Because wherever you get ill, you should know you're going to get the most effective care. And so there would be standardization, there would be reporting on their outcomes and their processes in the same way, organization to organization. And once we had that in place, we could continue to improve them. And so under, the Obama administration, this was really a Medicaid demonstration. And I remember, Patrick, going and learning some things in terms of how Congress works was fascinating for me, because our big thing was we had to stay under $1 billion. When you got to the big B word, there would be like a third rail. And so we had to spend $999 million on this 2-year demonstration. And the purpose was a one-stop shopping, that you could get addiction care, you could get care for mental illness, you could get care coordination, you could get screened around your primary care needs and connected to primary care, and there'd be a single point of accountability. I don't like when the answer is it's the team's responsibility. I think it needs to be a person's responsibility, and in this case, an organization's responsibility. And so we got this demonstration. When the Republican administration, Trump, came into office, they were not going to use Medicaid money. There is this kind of notion of Medicaid recipients sitting by swimming pools, drinking beer and smoking cigars, which of course is the furthest thing from the truth. And so it became a grant program. I think we have some expectation in the new administration that we may be able to look at an expansion of Medicaid and maybe even a public option in insurance. And I think that will help even move this further along. But there should be one place in every community where you can get 24/7 attention, where people hang in with you when you're in crisis, and then provide long-term treatments and support based upon the best available research. So we've got pockets of excellence. Now we want to make every community excellent.
Well, it's interesting that what you've done is so successful. Not only is imitation the finest form of flattery, and the private sector is emulating the public sector here, but they acknowledge that what's missing in the private sector is often what the public sector can bring in terms of those additional resources that help people in their lives through human services that address some of these political determinants of health, poverty, housing challenges, unemployment, food insecurity, and those things. So talk a little bit about how crucial those things are to a person's mental health.
So, one of the things about mental illnesses, and I want to get a chance, I hope, to talk a little bit about mental illnesses and what we mean when we say that, because I think we mean a lot of different things. And the public also thinks and has a vision in their mind of somebody with mental illness. But I think one of the things we know about addictions and mental illness is people are drawn into poverty. And so more than any other illness, it's much more complex, because when you're poor in our country and in our communities, housing, food, school, safety, all become issues. And if you're both poor and a person of color, you have barriers that are often insurmountable. And so I think we have to acknowledge that the public sector has a role to play in these illnesses, and far beyond perhaps other illnesses. So, 3 years ago, I had heart bypass surgery, actually at Columbia, before I was employed there. And what they did for me was very effective. It would have been the same in most cities across the country, but they didn't have to also think about where I was going to sleep the night they discharged me. Or was I going to be able to have a diet high in fruits and vegetables? Or was I going to have to worry about whether my child was getting a decent education or not? And all of those things become issues when you have a serious mental illness and a chronic addiction. You really have to worry about the whole person and all the services that touch them. And I think that's a real difference. And it makes an important role for government and the public sector and the not-for-profit sector, which you don't necessarily have in other illnesses. And you don't have if you also, come to the table with lots of resources. Managing and navigating healthcare, and then specifically mental health and addictions, is hard enough when you're connected and have resources. When you have neither resources nor connections, it becomes virtually impossible. And we have to create communities that make that easier for patients and families.
So the jailbreak for us in this movement will be when we can start to have attribution to certain interventions and then be able to use that as a metric in evaluating whether a form of treatment is effective or not, based upon whether it's used to address the person's needs in a way that can be measured in terms of not only the reduction in maybe rehospitalization or relapse or incarceration or any number of other kind of indicators. So talk a little bit about this idea, because you're wrapping your arms around the fact that if this is a complex set of illnesses where you have all of these data points,
Right.
that are combined with the metabolism and the biological and the medical. Now you've got the social, emotional, spiritual piece to this. How in the world do you put all that together and then come up with a billing model that ensures that the things that are going to be important to someone's health are also paid for? This is obviously new territory, but tell us a little bit about what you're seeing out there.
Yeah. So I think two things. One is obviously prospective payment, right? Which you mentioned earlier and is a complex, term. But what it means is right now, health centers get paid based upon what people cost them. What are the services people need that they're going to provide? And then there is an accounting for that on a weekly, daily, monthly, yearly basis. So that's one of the things that CCBHCs bring to the table. The other is if you have an organization that has this total accountability, and I think it is an accountability, and we've got to hold these organizations accountable. One of the ways you do that is by having measurement and benchmarking organizations against each other, which people are very reluctant to do in healthcare, but is really what creates change. I have a great interest in rewards and punishments and how they shape behavior. So I do think that is an important piece. I think at the patient level, what we don't do that other parts of medicine are far ahead of is measure improvement or lack thereof. And it's okay. Not everybody's going to improve. And certainly they're not going to improve at the same rate. And so we tend to avoid it. And we also, mental health comes from a world where everything was done behind closed doors. I mean, I think that's one of the things that technology brings us is transparency or the potential for it. So if you measure how people are doing and you report those measurements, and we have systems that then benchmark organizations against each other, you can begin to see a picture of how people are doing. Right now, we know which hospitals have the best outcomes in several different illnesses because they've got to report that. Well, if we have these CCBHCs and they're reporting that kind of data, we can begin to look at and see who has better outcomes. And there are ways to risk adjust depending upon who they're working with. So this is really complex, but doable. And I think you're going to see advancement in the coming 5 years at both the policy level, but also at the practice level.
Calling all mental health providers. Looking to specialize in treating adolescents? Check out Psych Hub's cognitive behavioral therapy courses. Receive specialized certifications and hone in on your skills. Get 1-year access to patient videos and worksheets that you can email or text to your clients to keep them engaged in between sessions. Plus, you'll be placed on the Psych Hub registry, where consumers of mental health who are searching for certified providers that are specialized in their condition can find you. To learn more about CBT for adolescent training, visit psychhub.com/learning. I appreciate it too, because I think where you're going is the future of mental health, right? It's like, where are we driving all of this forward? So you mentioned that you wanted to touch on mental illness. And I think that's a really important piece, especially also when we're looking at outcomes, right? Because measuring outcomes, as we've come to learn at Psych Hub, is very complicated. It isn't as easy as, do you have strep throat and do you no longer have it? And it's different for everybody. So if you can elaborate a little bit on where you wanted to go on mental illness and then measuring on that spectrum of mental health.
So I think, when you talk about someone with mental illness, I think what the public often thinks of is someone who has a psychotic disorder, right? Someone who's been diagnosed with schizophrenia, maybe living in the streets. When a person breaks their leg and goes to the ER, they'll see someone in the ER who looks disheveled. Maybe they're talking to themselves. Well, that's at the end of a continuum, right? And that group of people who struggle with serious mental illness, they also can get better. They need many of the things Patrick was talking about, right? They need not only effective treatment, and we've got to be transparent about what they're getting, what works, what doesn't work. And they also need, though, housing and food and medical care. That's one end. But then we have other illnesses, in that, under that same umbrella: depression, anxiety, OCD, eating disorders, and they are different and require different kinds of interventions and often come upon someone in their life at different stages. And so I think we've got to sometimes think about that, because when you're talking about measurement, the measures may be different because the disorder's different and our interventions that are needed are different. So we have some really exciting work going on now in, treatment-resistant depression at its extreme, in terms of the use of, hallucinogenics. That's a whole new area going on there. In terms of eating disorders, we have new kinds of interventions, and we don't often talk about that, and we don't differentiate, but I think the public needs help with that. They don't always understand, what is it I'm seeing and what should I expect in terms of treatment?
Linda, there's a phrase in recovery: not about me, without me.
Right.
And I like this idea that you can take the templates, but you really need to personalize the care. And
Absolutely.
it's really no different than what we do in other areas of medicine. My dad got, radiation, chemo, other forms of treatment. It was a combination approach. And that's true with other types of interventions. It's with HIV/AIDS, it's a combination therapies and so forth. And we're talking about combination therapies and based upon the segment of severity and the type of illness. So you're kind of getting into the more specified, here in this area are the likely interventions, but it'll have to be customized
Yes.
for that person. And I think that this is a whole psychological game changer in the mental health movement because, we've never thought with that degree of specificity when we come to treatment of mental health. It's kind of this blanket. Do they go see a therapist?
Right.
Do they have a shingle on the side of the house or the office? So talk about this huge revolution that we're in the midst of right now in terms of how we think about mental health.
I have we all do, right? I've been around a long time. I have certain notions. One is I think we have to give up the notion of a mental health system, like we're going to have one system. We had one system in every state when everyone was in a state hospital or they were considered fine and well if they were not. Those days ended in the 60s when we created, community services all under different auspices. So sometimes it's easier to get treatment now actually in a rural area than in New York City, where there is so much available that navigating it is very difficult. So I think we have to think about neighborhoods in many ways, or one system. So Columbia is a system. Mount Sinai in New York is a system. Jewish Board is a system. And so where do we put accountability, particularly for those people who need all of those services, Patrick, you describe, all those political decisions we have to make about housing and food and race? Where do we ascribe, responsibility? And I think we have to think about that. And that was the notion of the CCBHC for people with addictions and mental illnesses that need public support because their illness is disabling, and they will need support over a long period of time. I think parity and holding parity's feet to the fire, the insurers. And by the way, I think insurance companies are fabulous. They have some of the best people working in them, running in them, but we have to understand their business. And they'll do what they're contracted to do. And that's where I get very interested in this whole notion of rewards and punishments. But I think we have to demand, as do the payers, the employers that are using these insurance companies, right? And you're very involved, I know, in something called the Path Forward, which is working with employers to make sure that people who have illnesses like depression, anxiety, but they're working and they're able to go to work most days and they're able to raise their family most days, that they have access to the best care that's available, the most effective care. I think effective is an important word, and that they're also measuring. So I think we always lag behind other disease states a bit, right? Because the brain is the most complex. It's the last frontier. And so we have to know that we don't have a blood pressure cuff, but we do have standardized instruments. And I think we have to begin to demand that they get used. Every time somebody's seen, if they're depressed, it's a PHQ-9. If they have schizophrenia, maybe it's the DLA-20. But there is a measurement, and then the patient with their therapist, whether it's online or in person, can really look at the results and adjust the treatment based upon those results. So I think it is very personal at the site of service. And then that data also at an organizational level gets collected and compared. So we have a long, long way to go. And we haven't even talked about prevention and children and schools, where I think really we need to look if we're going to try to create a different future.
I will say on the Psych Hub side, we're running into these quality outcome measures and agreeing. And I'm happy to say that we have the chief medical officers of behavioral health of every one of the national health payers, Aetna, Anthem, Humana, Cigna, Centene, Optum United, all on our scientific advisory board and all on a working group on this common quality outcome measures. So exactly to your point, that at least everybody can agree on. And even though, to your point, private health insurance is different. However, many of them have the Medicaid contracts too. So we feel like if we can bring all of them together and and they all know, these are not typically friends. They're not typically friends, but they've come together for this common
And they respect
work.
each other. They have great respect
Yeah.
for each other. Many of them have worked in several different companies. I always think that the best thing to do is start with something. Have them measure just two different things. I think once you go down this road of trying to come up with the perfect set, I stopped going to those meetings because I couldn't stand it anymore. That somehow we were going to come up with a perfect set. I think if they all begin to demand and require that every time someone with depression has a session, that the PHQ-9 is used and that the treatment plan is adjusted. I think that's pretty simple.
We're advocating that the provider gets paid for processing that assessment with their patient.
Very kind. I think just do it.
And that is actually working. Excuse me. So that incentivizes at least the provider to start to measure. We just need to start somewhere.
No, I agree. You need to start somewhere. And not the medical director, the CEO has to want it. In my experience, what the CEO wants is what gets done. And the medical directors are sometimes sent to meetings and they talk nice talk, but in the end, the decisions are made quite differently. I hope no medical director is going to shoot me for saying that.
So, Linda, we're talking about accountability. We're talking about incentives. What the big picture is the money.
Always.
It's really about having the total pot of money on the table, because many of these payers, they're not true fiduciaries. They're fiduciaries for their little piece of the pie. And part of the reason why we don't get a more comprehensive, organic picture of what someone's health status is that it's divided up across many different sectors of budgets or otherwise organizations or quote systems who only represent a piece of the total and therefore cannot appreciate the value of the other pieces because those are not their exposure.
That's right.
In terms of the liability.
Yep.
So we really need to figure out this financial piece, because if it's the financial piece and you truly said, well, if we do this and we reduce the number of times that the fire engine and the rescue has to go out, and then that you're going to have a couple of police cars too to supervise, the person with mental illness if they're under the influence of drugs and alcohol or they have a psychotic break, being, escorted into the ambulance and driven to the hospital, where then they also have to be supervised while they are basically boarded forever because there's no place for the hospital to then transfer them. And God forbid they're sent to the jail because that they have some criminal infraction and they have to be written up for that and then processed. And you start adding all of those dollars and say, if those dollars are the dollars we're going to be accountable for, well, then this is pound foolish, penny wise to not spend the money early in ensuring that people are stabilized. And it may not be like you quote, if you're a very conservative person, oh, I'm not going to get my ROI on that person if the largesse of the public money goes to helping this one person, because we always think of it. But if you take a population snapshot and say, as a whole, we get a huge return on investment as taxpayers if we take the approach that we can't silo these people out. They're everywhere. They're on all of our health plans, one time or another. They're on all of our governmental agency budgets, one time or another, education budgets, labor budgets, commerce budgets, veterans budgets, defense budgets. It just doesn't make any sense for us to have these data points in a sea of unaccountable dollars, because we'll never see the true value of what you're talking about unless
Patrick,
we get the budgets on the table.
But, Patrick, what you're talking about is interfering with business. Everybody's making some money in the picture you paint, right? Organizations are existing because they get money for doing that piece of work, of which they often complain, by the way, but they don't necessarily want to give up that funding stream. So what you're talking about also requires a lot of political will that we don't always have. Joe Parks, who's the medical director at the National Council, he was the Medicaid director in Missouri, always says every time we have to make a decision in healthcare, we make a decision good for business. And so, taking these things apart is very, very difficult. And really, we have to think about at what level can we intervene to bring those pieces together? And how do we ease the loss for some organizations? One of the things I learned in New York when I was the senior deputy commissioner is when we wanted to do a new innovation that would take away business from something that already existed, we had to help that old business, and that's that old not-for-profit, survive and make a transition over time. And we don't always realize that. And so what you're talking about will require political will. It won't necessarily save money in the short term. And I am, in terms of healthcare, as a group, mental health and addiction advocates spend too much time promising to save money in other areas. I've never seen other diseases talk about that. So I know I'm an outlier in my stance, but people deserve effective treatment. But what you're talking about is at the community level, bringing together all and braiding together all those streams that one family that is really suffering is dealing with. There can be one family that have five case managers because they're involved in a different housing agency, a different a substance use agency, a different mental health agency, school, alternate school organization. And so how do we begin to holistically move that agenda? And maybe that's going to be really the new frontier, is really struggling with that.
Linda, I think just having people like you thinking about these complex problems and really just putting your years and decades of experience, because as we know, these aren't going to get solved right away. You said earlier that one of your best strengths is knowing good talent, and I actually wrote down.
I hang out with the two of you.
Hey, what I was going to say.
Well, you're clearly a good politician too. We love it.
And I was going to say that actually, I think one of your greatest talents is also you're a real innovator. And then you brought up later about, innovation. And I think that we're so lucky that you took a shift to go from national council to academia, where we have and I'm just shifting over to this for a minute because I think it's so important. We have the greatest, brightest minds working on this research. And you and I have talked before, this pendulum swing of, was it 12 years or something, to get common information out into the world. And I see you in this role of trying to close that gap and let's get the best information out to the general public. Tell us just a little bit about your new role, your new job, and what you hope to see, since we all already know that everyone wants to copy what you do anyways. What could you tell everybody else at universities out there they should be doing?
I think it's exciting. The Columbia Department of Psychiatry is what it is because of our chair. I think Jeff has been there, 15 or 16 years, and it's never good enough for him. So he is very committed. At one time he was president of the American Psychiatric Association. He's very committed to improving lives and wants us very much to be part of the community. The other thing interesting, Patrick, is when all of of the national advocates get together, right? Very often the hospitals are left out, although they still deliver a huge amount of the care in addition to research, and they're training almost all the psychiatrists and psychologists, who then go back and do the research and do some of the work, and some are in some of the leadership positions. So I think it's interesting to be here now and to try to move them increasingly into the community, which they very much want to do. I was at a meeting with the New York State Office of Mental Health and a lot of the providers in New York City, and they were talking about, the relationship between hospitals and community, mental health organizations. And the truth of the matter is, the hospitals would like to have more, integrated approaches, but they're paid differently, and they can't afford to do community services. They don't pay enough. So that too is tied back to money and how things are allocated and how they grew up over time. But I think, we're in the middle now, in addition to the work, that you're leading, Marjorie and Patrick, around bringing some expertise to the public in different areas of mental health and addictions. We're doing a new project with libraries. I grew up as a working class kid, grew up in a housing project in New York City, and the library meant the world to me. And so I think, just like schools, libraries can be important places for kids, for families, for teens. And so we're trying to integrate and bring mental health to the libraries, as New York City started to do. We're trying to add to that, and we have a project around that. So I'm involved in a number of things that have to do with bringing our expertise out to the community. How can we train community workers? In mental health, we spent a lot of time talking about peers and the power of peers in helping each other. I think we can do the same thing at the community level. One of the great projects that came out of Africa actually were friendship benches, where, grandparents went and had benches where other people could come and ask for advice and help. And it was really a mental health initiative. We have the barbership initiative. So I think there are ways that academic centers that have done research in the areas can bring it out into the community. And I'm really struggling to find more and more ways to do that.
Well, it takes a certain disposition to see the humanity in the services that are delivered from a healthcare point of view, but moreover from just a basic human dignity point of view. That changes the whole paradigm, the whole approach. So we're grateful to be your friend, to be considered as your colleague. You really have been a huge mover in this space, Linda, at that most important time. If we're able to get expansion to cover CCBHCs and really take this unprecedented crisis of overdose and suicide, which is an existential crisis for our country, and solve it with a solution that you've spent your life helping to really push out there. I hope you take your measure of satisfaction at a life that has made a big difference to many, many people. And thank you. I love you. I think you're the best. And we've loved having you on this podcast.
And I will put a shameless plug that we get a work at Psych Hub with Linda on another podcast at Columbia University called Ask the Expert. And it has been so much fun. I have to say, I've learned more hosting that podcast than I think I've learned in my whole lifetime put together. And these incredible professors. I didn't know there was 1,000. So I have a feeling we're going to have lots and lots and lots of episodes. But we tackle different topics and different subjects and different areas. And it's been a pleasure working with you in that regard. And just in all things, Linda, you are a true gem, and we're so grateful. Thank you.
Grateful to both of you. And this is our moment in both mental health and addictions. And so we need to take advantage of it.
Thanks.
Hey everyone, it's your friendly neighborhood Kevin Hines, and here is your brain health tip of the week. Be socially connected, while physically distancing. Whether you are a pick up the phone and call kind of person or always on the latest social platform, there are so many ways that we can stay genuinely connected while apart, physically. Delete the accounts that don't bring you joy and happiness, and follow or subscribe to the ones that do. Follow me on social and Psych Hub for self-care tips to interact with people that care about mental health today.
As always, thank you for listening to our podcast.
If you enjoyed the show, drop us a review.
If you haven't already, subscribe to our podcast for the latest episodes.
For the latest insights, check us out at psychhub.com.
You know that airplane metaphor of putting on your oxygen mask first before you help someone else? Mental health is no different. In order to take care of others, you have to help yourself first. But what does that look like? Take Psych Hub's Mental Health Ally certification for starters. It's 8 one-hour courses covering anything and everything, from substance use to diversity in mental health, how to help others, suicide prevention, and more. Plus, it's self-paced, so you can take it at your own schedule. Become a certified, trusted resource to come to for mental health concerns. Visit psychhub.com/learning to get started.